Well, a warm welcome to this talk, and I'm delighted to welcome back Dr. Michael Cohen. Dr. Cohen, welcome and thank you for coming back.
Thank you for having me, John.
Now, you've seen shall we say, small cohort of patients over the last year or two presenting in a slightly unusual way, things that are inconsistent with what you've seen, presumably over your other medical life. What sort of things have you been seeing, and how many patients are we talking about?
Okay, well, I have a clinic which sees, I look after about 1,000 plus local patients in this clinic, and I also every year something like 2,000 to 3,000 other patients come through. That's not the it's a pretty significant number of people to see, let's say. And I would say that during COVID and since, I saw quite a lot of people with very similar types of diverse symptoms. And very often these were neurological symptoms. Some of them were cardiac symptoms, so neurological meaning brain symptoms, cardiac meaning heart symptoms. And these were symptoms that varied from severe pain in a limb, numbness, tingling, but really disturbing things, not just a mild tingling, to the point of being unable to walk at times when this happened in the acute setting. Cardiac symptoms where people had racing hearts, extreme fatigue, breathlessness, and a lot of the time the interesting thing was there wasn't much to find when we would send people for tests, and I'd send people for quite extensive tests, whether it be an MRI of the brain, it could have been a stress echocardiogram of the heart, which is an ultrasound of the heart done under exercise conditions. You had to rely not just on the history, but also on the examination. But you could see there was evidence of these things happening. People having heart rates of 150 at rest, being unable to do a very minor exercise when they were usually fit athletes. So these are the kind of symptoms that I've seen quite commonly in these last couple of years. And I can say, again, these are not things that I can prove, but I can say that I saw a lot of people who had symptoms like this either after COVID or after a vaccination of COVID. And I've seen people also who had a vaccination, they had these symptoms. They'd been told by a number of people, well, it's not the vaccine, or it's in your head. And then they'd gone and had a second vaccine and the same symptoms occurred very soon afterwards. Maybe as severely, less severely, a little bit more severely. And it's very hard to ignore stuff like that and just say, well, oh, this is in your head, or it's stress or something like that. So that's what I've seen.
So we are talking about temporal correlations here. That's about as far as we can say from the family doctor perspective.
Yeah, I can't prove more than that. But these, again, it's a little bit like if I go back to vitamin D 3 years ago. There was some kind of weird association there that it wasn't so weird, but there was an association there, and we try it, and it seemed to have worked. And only later, a year, 2 years later, we're seeing all of these studies showing that vitamin D was actually incredibly important. It could have saved millions of lives.
And this is something that you almost derived intuitively from your own practice.
Pretty much. You don't have to be, it's not rocket science, honestly. It's just looking and seeing what's going on around you.
It's not that you're the one that worked it out, Doctor, so there is a difference.
No, I mean, plenty of other people worked it out as well. It wasn't that hard to work out. I think what was more concerning was that it was so hard to publicize without being ostracized for it.
Yeah, absolutely. We won't go down that track at the moment. So, but suffice it to say, it sounds like you're seeing extreme tachycardia, which, I mean, a heart rate of 150 at rest You know, if we're talking about someone who's normally fit, a heart rate of around about 60 to 70 is probably what we would expect. And
Yeah.
it sounds like you're
Yeah.
seeing peripheral nervous system and central nervous system symptoms from the way you're describing it. So we're
Yeah.
seeing really substantial pathological clinical features here.
Yeah. If you want to talk about cardiac stuff for a moment, I saw someone fairly recently. She, very fit lady, does sports on a regular basis, on a daily basis, I would say. She had these tachycardias at rest and stuff. And I think what happened with her, I can't remember actually in her case right now if it was possibly due to COVID or the vaccine, but I'm pretty sure it was one or the other, because it started soon after one or the other. And she had something called POTS syndrome. And POTS syndrome means postural orthostatic tachycardic syndrome, which is a bit of a mouthful, but basically it means that the autonomic nervous system, so you have the central nervous system, which is in the brain, you have the peripheral nervous system, which is all the nerves that come out of it, and that divides up into both the autonomic, which is part of the system which we are not aware of, and then the conscious nervous system, which is when I want to move a finger, I can just tell my finger to do that. The autonomic is less in our conscious control, but even that is in partial conscious control, where you can actually slow down your heart rate or raise your heart rate. That's a system that's moving along all the time. It has its own rhythms and rates, and one of these syndrome called POTS, I've definitely seen a lot of it during COVID, due to the illness or due to the vaccine, can't always say, but I've seen a lot of it, and it's a syndrome that hardly anyone ever mentioned before COVID. And it has a lot of different features, including fatigue, including low blood pressure. But that's something that I've seen a lot of. And as you'll see, we'll talk about a case, I think, of somebody who I saw going back 2 years now. And I think that a lot of the things that she presented with do match up with a POTS type diagnosis.
Now, one of the reasons I'm delighted you're on the channel is your approach where you consider basic things first. It's like, think of the simple things first, and it's the main things are the plain things, and the plain things are often the main things. What are the sort of basic things you look at really in any patient before you get down to what we might call more sort of sophisticated medicine?
So if we're talking about, I assume you're talking more about treatment right now rather than diagnosis.
Well, yeah,
I mean, in general, common things are common. So
the things about looking at good nutrition and things like that. What's your sort of approach there?
Right. So okay, fine. So if we're talking about the basics, I think for everybody the basics are good nutrition, which is not always obvious as to what good nutrition is, and it varies a little bit from person to person, for sure. Sleep, having enough sleep and having good quality sleep. Keeping stress to a healthy level. I don't say don't be stressed. I think that's ridiculous. We all have stresses, and it's really about there's a certain level of stress that's good for us and that is useful for us and that's important for us to have. And then there's too much stress and probably too little stress. So in addition to sleep and nutrition, there's exercise. Exercise is something that should be being done every day virtually in various forms. It doesn't mean that you have to run a marathon, but it does mean that you should be active on a daily basis, and certainly should be doing some kind of sports, both for physical and mental well-being. These are the things that really do matter. And one other thing that's perhaps less obvious is having good relationships, so good social networks. I would add to it living meaningfully, so having something that gives a person meaning in their life. I think that's incredibly important. You need whatever it is. It doesn't, everyone's different, but you need something like that to keep healthy-minded and also healthy in your body.
So any of these things that are deficient, that can lead to a patient coming to see you, and it could turn out to be something as simple as one of these basic components?
Absolutely. I mean, nutrition is the obvious one, but obviously sleep is incredibly important. So a lot of people don't sleep well or have very disturbed sleep, and that leads to illness. There's no question about it, both physical illness and mental illness. In addition to that, if I was to think in the realm of nutrition, there are certain vitamins and minerals in the body which are commonly deficient, and which we only really need to look a little bit harder for. One of them very commonly is iron. We've spoken about that a while ago, about a year ago, I think. And another one is vitamin D. I could go through others. There's vitamin B12, there's magnesium, which is very hard to detect, to know if it's deficient in the first place, because the blood test doesn't really pick up a deficiency. It can show if you've got excess magnesium, it can show if you've got too little magnesium, but if your level of magnesium on a blood test is normal, because it's what's called an intracellular ion, it means it's mostly stored inside the cells. The blood test, which looks at the plasma, which is outside of the cells, doesn't show well what the actual level of magnesium is in a person. And so, and there are reasons to think why there's a significant amount of magnesium deficiency around the world today. But yes, so you're looking at deficiencies, but you're also looking at optimal levels. So I could say a vitamin D, considered a normal level of vitamin D today, is supposed to be 32 nanograms per milliliter. If you times that by 2.5, you get it in millimoles per liter. However, all the studies for COVID to date have shown that you need to have a level above 50 to give adequate and good protection, not just from developing severe illness in the first place, but also from probably preventing ongoing sequelae, ongoing complications, long COVID. It's important to keep that level up. And most people will not get anywhere near that level. And people are varying in body sizes as well. So if you are on the chubbier side, you are not easily going to have a good vitamin D level. Same thing with iron. We measure ferritin. Ferritin is it's a protein that's bound to iron, and so we measure the ferritin level. The lab results say your ferritin is normal if it's 13 or above. In reality, in clinical practice, if I see patients who've got a ferritin less than 50 on a regular basis, on a chronic basis, they're much more likely to get unwell, or to have recurrent illnesses, or not to recover so well, or to be chronically fatigued. Those are two examples.
And magnesium, of course, we now know there's data on that magnesium itself is very important for sleep.
It is. It's important for sleep. It's important for hundreds of chemical reactions in the body. It's important also for vitamin D. So if you don't have good magnesium levels, your activity of vitamin D may be impaired somewhat. Magnesium has other functions as well, which we won't get into right now.
But it's an interesting one for deficiencies, because a lot of modern soils, which use a lot of fertilizers, have become depleted in magnesium.
Mm-hmm. Absolutely.
Magnesium is found in offal, like heart and blood vessels, which we tend not to eat.
Yeah.
But the fact that a lot of magnesium is found in the heart and blood vessels, to me, indicates it's probably important for my heart and blood vessels. So it's
well,
not there.
You can make that inference. I don't know the science on that to be. It's not. You may be absolutely correct, but I don't know for sure about that. But I imagine that there's a lot in there. Yes.
And I think iodine's probably another one as well, that you live fairly close to the sea, so maybe it's not such a problem.
Also, I'm sure there's quite a bit of thyroid disease as a result of iodine deficiency. And again, the test for iodine is not so simple. You have to do a 24-hour urine collection, and that's not going to happen on a mass scale.
Mm-hmm. So patients come to you, and you're able to screen them really for these potential deficiencies. And if you find a deficiency, what do you do if you find a particular deficiency?
Well, the first thing obviously is to think, why would someone be deficient, right? Are they not getting it in the first place? Are they not getting enough, let's say, B12 in because they're vegetarian or because they're vegan? Are they using up a lot of iron because they're breastfeeding, because they're pregnant, because they have heavy periods, because they have Helicobacter, which is an infection of the stomach by a very well-known bacteria that causes an inflammation of the stomach, and it affects the absorption of both iron, B12 and folic acid. It's about, first of all, thinking, why is there a deficiency here? So does someone do a lot of sports, so they become iron deficient even though they're eating a reasonable amount of meat? Their body needs to use it. So the first thing is you find out, why do you think they've got the deficiency in the first place? And then the second thing is, is there a problem that really needs treating? Meaning, someone could have a cancer, for example. You can't just treat someone with iron and assume that there's no reason for it. Most people won't have a cancer, but you have to bear in mind that it could be that, or it could be something else. It could be celiac disease. It could be pernicious anemia, which is when the body has antibodies against, basically against the ability to bring in B12 into the body in the first place. And that can also affect iron. So all of these things need to be considered. And once you've considered that, then you can also say, well, in the context of this person's symptoms, what do I need to do to treat them? Do I need to do anything or not? And as long as you are acting safely, so you're using safe doses, and you're monitoring the patient to see, well, is this treatment actually working for them? You can often see very clearly when something works. And to come to a broader point about this, because we've mentioned in the past when we've spoken about penicillin, for example, in the 1940s, how it was, this was seen, we found a target to treat. So medicine went from being very much looking at the whole person to saying, okay, we now know that there is this bacteria, strep, for example, and Streptococcus bacteria responds to penicillin, and we are now going to target that, and that's going to treat various diseases, which we know that it does. It treated rheumatic fever, it treats streptococcal sore throat and the potential complications. But it also got us thinking in a way of, okay, everything is targetable, right? If I have an illness like cancer, I just need to find the target cells and treat them, which is great. It's all good. The only problem is that the body is so complicated, and we need to be looking at what is the milieu of the cells around the cancer cells, for example, or what does the body need to function best to deal with an infection, let's say. And this is the issue when things like vitamins, nutrition come in. Sleep, all of these things. If you can ensure that a person is generally in the best position to be healthy, then you're already off to a winning start in trying to treat them for something. And very often, you may have someone who gets recurrent infections, just recurrent sore throats or bronchitis or whatever it is. And so each time they become ill, we say, okay, well, we're going to give you a course of antibiotics or not. It might be a virus. We might just say, go home and rest. But we need to think about what's going on underneath that. What are the best contributors to them having a healthy working immune system? And what should we not be doing in terms of, obviously, we don't want to harm, right? The first thing is we want to improve somebody's health and not harm them. So all of our interventions have to be safe. As a first point, and that's the basics of treating somebody. Sometimes when we may know the diagnosis, or we are not 100% certain what the diagnosis is, but we know that it's nothing too terrible. We can treat with these other things in addition to, let's say, a typical drug that might be being used for that condition.
Getting these basic things right will optimize the body in order to respond to a treatment and hopefully prevent the severity of future illness, or indeed prevent illness that was caused by these particular deficiencies.
Absolutely. And I see it time and time and day. Sorry, go ahead.
Yeah, I just encourage. No, I was going to say I'd encourage more doctors around the world to order these basic diagnostic tests, because I know in the UK at the moment it's pretty hard to get them actually. So
I think it's a little bit of a shame because
right.
Well, I mean, I think, even if you start looking at things from a cost-effective point of view, if you can just get people to have good nutrition through whatever means necessary, meaning either through social policy or through making sure that it's possible to do some basic cheap tests, I see little room for harm there and a lot of potential good.
I agree completely. So that's looking at the basic approach that should be really applied to every patient in the context of what we've seen over the past few years, or you've seen over the past couple of years, and in terms of promoting health and family medicine in general. So plenty more to come from Dr. Cohen. That's all we're going to do for now, but do look out for the next video. And Dr. Cohen, thank you very much. And if you choose to come back to do some more, we'd love to have you again.
I'll look forward to.
Thank you.
Thank you.